Now moving on to the next topic, obesity, the menacing pandemic. As we all know, it's a complex multifactorial problem that nearly every nation in the world is facing, but there is much that we can do to fix it. It affects every aspect of people's life, from mental health, physical health to relationships. According to WHO, worldwide obesity has nearly tripled from 1975 and nearly 13% of adults in the world are obese. So here we are expecting to boost up our knowledge on this topic from our experts. As the management includes lifestyle changes, medications and surgery, we have chairpersons from different specialities, and I would like to invite the chairpersons on the stage. First of all, I would like to invite Dr. Mohit Jain sir. He is Professor and HOD of Plastic Surgery Department in MLN Medical College, Prayagraj. We welcome you, sir. Dr. Vaibhav Srivastav. He is Professor in Surgery Department, MLN Medical College, Prayagraj. We welcome you, sir. Dr. Sujit Verma. He is Professor in Department of Medicine, MLN Medical College, Prayagraj. We welcome you, Dr. Sujit Verma. Dr. K.K. Sonkar. He is DM Neurology and Professor in Medicine Department, MLN Medical College, Prayagraj. We welcome you. I would request one of the chairpersons to please introduce the speaker.
I think, sir, he is the undergraduate, postgraduate of the Department of Medicine. I think all the four of the chairpersons have taught him. So I think it's a privilege for Alankar to speak again.
It's my privilege to introduce him. I welcome Dr. Alankar Tiwari. He is DM in endocrinology, MBBS and MD, as Dr. Anwar told, from our own medical college. He did his DM endocrinology from Meerut Medical College and is currently working as consultant endocrinologist and dermatologist at Apex Super Specialty Hospital, Varanasi. He has many research papers numbering to 22, case reports, abstracts in various journals, and he is member of various organizations like RSSBI, API, ESI. I welcome Dr. Alankar and I request him to start his presentation. COVID may have been a pandemic, but I don't think it will last very long. But obesity as a pandemic is here to stay, and I don't know how long it will last unless there is a revolution in public awareness and health awareness. I think obesity is a very big problem, and I'm sure Dr. Alankar will be presenting a very nice talk.
Thank you so much, sir. First of all, I am very fortunate enough to be here in my alma mater, and thank you so much, Dr. Anubhav ma'am, to inviting me here for the talk and speaking in front of my teachers and mentors. It is such a privilege. And as the sir said, that we have already facing a pandemic of a virus already, like COVID-19. But this non-contagious pandemic, or certainly contagious, obesity is also increasing at a very alarming rate. As we have already known that about 1/3 of patients all over the world, they are suffering with this disease, obesity, and most of them are not yet conscious about this, that they are suffering from obesity, or obesity is some kind of disorder. So we have to make patient first of all aware. We have to make and inculcate an insight in the patients, subjects, that obesity is a disorder, and along with a disorder being itself, it is a root cause of many other disorders, lifestyle diseases, others like diabetes, hypertension, and other cardiovascular diseases. So without wasting much time, let's begin the talk. Obesity is a complex, multifactorial and largely preventable disease affecting, along with overweight, over 1/3 of world's population today, and thus getting named a globesity pandemic. So we have come up with a new term, globesity, because it is all around the world, whether it is developed country or developing country, obesity or overweight is everywhere. So we have come with a new term, globesity pandemic. WHO defines overweight and obesity as an abnormal or excessive fat accumulation that presents a risk to health. The prevalence of overweight and obesity has increased dramatically in recent decades, both in developed as well as developing countries. And people are becoming obese younger, morbid obesity is increasing, and the full health implication is only the beginning to be seen. So now obesity is a global epidemic, or we can say pandemic. Now what the various organizations and authorities says about obesity epidemiology is it is recognized as a disease and a global health issue. According to the American Medical Association, recognizing obesity as a disease will help change the way the medical community tackles this complex issue that affects approximately 1 in 3 Americans. WHO says that obesity is a chronic disease prevalent in both developed and developing countries and affecting children as well as adults. Canadian Medical Association says it is important for healthcare providers to recognize obesity as a disease so preventative measures can be put in place and patient can receive the appropriate treatment. Organization for Economic Cooperation and Development, this organization says that overweight and obese people are a majority today in the OECD area, and the obesity epidemic continues to spread, and no OECD country has seen a reversal of trend since the epidemic began. So the prevalence of obesity worldwide, this picture shows that around more than 135 million people worldwide, they are living with obesity. In India, more than 135 million people are living with obesity in India only, and in world it is around 650 million people. So you can well imagine how fastly and how rapidly this pandemic and this metabolic disease is spreading. Now there is a complex and multifactorial disease. This obesity has many multiple factors which affects and contributes to the obesity. The main component of discrepancy is between the energy intake and the energy expenditure. We have a hedonic input, there is adipose tissue, and the patient experienced a palatability or pleasure, and environmental factors are like food and other socioeconomic factors, and they together cause the energy imbalance. And the various organs involved are like adipose tissue, pancreas, gut, genetic factors, and medications also. So all these factors together contribute to the overweight and obesity disease. Now something about the pathophysiology. The progression from lean state to obesity brings with it a phenotypic change in adipose tissue and the development of a chronic low-grade inflammation. So obesity is actually a chronic low-grade inflammation, and thus it is characterized by increased levels of circulating free fatty acids, soluble pro-inflammatory factors like interleukin 6, interleukin 1 beta, and TNF alpha, and the activation and infiltration of immune cells into the sites of inflammation. So this chronic low-grade inflammation leads to vascular dysfunction, insulin resistance, and atherogenic dyslipidemia, which eventually results in various other metabolic and cardiovascular diseases. Now measuring obesity, we have many techniques to measure the obesity. The most common technique which WHO recommends is the body mass index, BMI. Other measurements are like waist circumference or abdominal girth and waist to hip ratio. Now this is a grading given by the WHO to grade the obesity. For the Asian Pacific classification, which applies to the Indian population, we have this a slight different grading. The normal range is from 18.5 to 22.9 kilogram per meter square, and more than 23 comes into the category of overweight. Similarly, we have obesity class 1, class 2, and class 3. We have another Edmonton obesity staging system or staging tool, which shows or indicates the severity of obesity. We have various factors. We have stage 0, 1, 2, and 3, 4. So in stage 0, there is no signs of obesity related risk factor, no physical symptoms, no psychological symptoms, and no functional limitations. While in stage 3, patient has significant obesity related end organ damage or significant obesity related psychological symptoms or significant functional limitations or significant impairment of well-being. So we can stage the patient, the severity of obesity according to this EOSS staging system. Now, association of obesity with mortality and comorbidities. Obesity is associated with a significant increase in mortality with a life expectancy decrease of around 5 to 10 years. And there is evidence to indicate that all-cause cardiovascular disease associated and cancer associated mortalities are significantly increased in individuals with obesity, and specifically those at stages 2 or 3 of Edmonton staging system. Obesity is associated with a wide range of complications affecting many different aspects of physiology. Like in this diagram, we can see that obesity can impact more than patient's weight. According to Obesity Medicine Association, there are 57 comorbidities associated with obesity, and it affects almost every organ system of the body. Now, this slide shows the prevalence of complications in people with obesity. 3% people with obesity can have stroke, 3.5% can have congestive heart failure, 8% can have ischemic heart disease, 9% can have PCOS, 19% they have depression, 21% people develop eventually type 2 diabetes, 21% may have myocardial infarction, 29% have non-alcoholic fatty liver disease, 35% patients experience GERD symptoms, around 40% they experience obstructive sleep apnea, 51% can have hypertension, and 52% patient can have osteoarthritis. So you can see that these a long chain of symptoms, number of symptoms patient of obesity can have. Now, relation between diabetes and obesity. Visceral obesity results in increased insulin resistance and thus a major risk factor for type 2 diabetes. And we Asian Indian population, we are a high risk ethnic group because we have a kind of lean obesity. Patients look lean from the outside, but inside they have increased visceral obesity, central obesity, which is quite harmful, and it increases insulin resistance, and eventually patient becomes type 2 diabetic and develop other cardiovascular risk factors. So visceral obesity is quite detrimental for patients, and 80 to 90% patients of type 2 diabetes are overweight or obese. A large study of around 21,000 adults in National Health and Nutritional Examination Survey found the risk rising from 8% in normal weight subjects to around 43% in individuals with morbid obesity. Now, correlation between obesity and cardiovascular diseases. A linear relationship has been found between body mass index and blood pressure. Even in children, those who are obese are approximately 3 times likelier to have hypertension than non-obese children. Many studies have found that for every 4 kg per meter square increase in BMI, there is a 26% increase in odds for coronary heart disease. Obese individuals have been shown to be twice as likely to have a stroke, either ischemic or hemorrhagic, than people with a BMI less than 23. Now, obesity and obstructive sleep apnea. Obesity has long been known to be a major pathogenic factor in OSA in adults, and OSA adversely affects multiple systems and is associated with hypertension, insulin resistance, liver dysfunction, and increased mortality. How obesity affects the immune system? With very important thing, obesity induces a dysregulated immune system which can be seen from childhood itself, and significant changes in both innate and adaptive immunity can be seen in obese patients. Associated with increased susceptibility to infections of numerous types, and obese individuals do not respond as well to vaccines also. And we have seen that in recent SARS-CoV-2 pandemic, high BMI has particularly been found to be a strong indicator of disease severity and mortality in patients infected with SARS-CoV-2 in many studies from all over the countries in the world. Now, obesity and gastrointestinal diseases. NFLD is strongly correlated with BMI and is considered as the hepatic manifestation of metabolic syndrome. And NFLD is now the commonest cause of chronic liver disease worldwide. Obesity is a known risk factor for gallbladder disease and also associated with greater risk of pancreatitis and is a poor prognostic factor for pancreatic patient. Increased incidence of GRD and is risk factor for esophageal carcinoma. Now, obesity and psychosocial issues. It is also very common in obese patients. They frequently face low self-esteem, depression, anxiety, and other mood disorders. So, the psychosocial issue is also a very common complication of obesity. Now, the management of obesity, the most important factor, how to manage and prevent obesity. Guidelines endorse weight loss targets of 5% to 10% in individuals with obesity or overweight with associated comorbidities, as this has been shown to significantly improve health-related outcomes for many obesity-related complications and disorders. Strategies to help individuals achieve and maintain weight loss. Structured lifestyle support should be there, along with other drug therapies, play an important role in successful weight management. There should be realistic weight loss targets, maintaining a food diary, and along with motivation and support. So the weight loss leads to improved health outcomes and towards greater weight loss and overall health improvement. So we can see that as we increase the weight loss, there is decrease in the other comorbidities and associated diseases like diabetes, hypertension, NFLD, and obstructive sleep apnea. So obesity is preventable. We can see in this picture that obesity, the world is getting fatter, and what are the factors involved in obesity, but still obesity is preventable and we have to focus on these things. Now, various modalities for treating obesity. We have, first of all, the foremost important management therapy is lifestyle modification. Then the lifestyle modification contains the dietary management and the physical activity and exercise. The drug therapies, pharmacotherapies which are available today for us are like GLP-1 receptor agonist, orlistat, norkestrone, phentermine and topiramate combination, and naltrexone and bupropion combination. And in surgical intervention, we have bariatric surgery today, which is quite promising in improving the outcomes in obese patients. Now, something about the GLP-1 receptor agonists, which are very latest and advanced drug therapy for management of obesity. The myriads of effects of GLP-1 in human body, how they can help they affect on various organs in body and improve the cardiovascular functions, liver functions, glycemic status of the patients, as well as helps in reducing the weight of patients. So here are some data from various real-world clinical outcomes, which shows that they have significantly patients who are on these drugs, GLP-1 receptor agonist, they have a significant reduction in HbA1c as well as weight loss when compared with the other oral anti-diabetic agents. Among the most effective medications for type 2 diabetes are GLP-1 receptor agonists, which have been shown to reduce HbA1c, body weight, composite outcomes, and even pill burden for the patient. So what is the challenge? The large molecules injection. Till now, there is a fear of injections may still remain a barrier to the use of GLP-1 receptor agonists in both patients as well as physicians. And a global survey of around 1,200 physicians all around the world, they have agreed, 26% have agreed that too many injections is associated with poor adherence to the treatment in patients. So what do patients prefer? From the vial and syringe concept in insulin diabetic patients, we have now pen tailored engineered pen injections, which is quite feasible for the patients. Then we have oral tablet form. Patient preference is more for the oral tablet forms. So from injections to oral, the convenience and compliance of the patient obviously increases. The rationale for oral delivery of peptides. There is an unmet need for safe, non-invasive and convenient mode of therapy. and improve patient compliance and expand treatment options which addresses the barriers associated with the subcutaneous injections of GLP-1 receptor agonist. Thus, we have a quest for first ever oral GLP-1 receptor agonist, and because the oral administration of peptide is quite challenging due to the enzymatic degradation in stomach, due to low pH proteolytic enzymes. Also, there is limited permeability and limited oral bioavailability of the drug if taken orally. So, what should we have now? We have Semaprotide, the foundation stone for peptide in a pill. It has a 94% homology to the human GLP-1 and the half-life is around 1 week. Some changes has been made in the this peptide chain, which increases the stability of this molecule. Semaglutide was the discovery which led to the path-breaking innovation in bringing GLP-1 receptor agonist inside a pill. So, oral formulation of semaglutide, how it could be possible? There is a co-formulation with an absorption enhancer SNAC. SNAC molecule has been combined with semaglutide, which has increased the long half-life of the molecule and also enhances the absorption of semaglutide along the GI tract. It promotes the semaglutide absorption, enhance the bioavailability of this drug. So the scientific breakthrough innovation, that is first in class oral GLP-1 receptor agonist, which is oral semaglutide. And the possible absorption enhancer, it can have a low bioavailability and absorption variability can be there. But it is mitigated by a 1 week half-life of the drug, and we have once daily dosing of this drug. Also, we have several treatment doses and patient compliance with dosing conditions. So 24 clinical pharmacology trials have been done for this oral semaglutide. The major are the pioneer clinical trials. One is the phase 2 trial and 10 phase 3 trials, which was conducted over around 9,000 patients. So these are some of the findings of this pioneer trial, and across global pioneer trials, oral semaglutide achieved an HbA1c reduction of around 1.5%. And 7 out of 10 patients achieve HbA1c within the 7% with oral semaglutide. And as far as the weight reduction is concerned, the patient experienced around 5 kg weight reduction with oral semaglutide in this pioneer trial. So these are the efficacy outcomes seen with the oral semaglutide. And how we will summarize this total oral semaglutide. It reduces the HbA1c and superior as compared to empagliflozin, sitagliptin and liraglutide. In weight reduction, it is superior to sitagliptin, liraglutide and empagliflozin. And efficacy was established when given early in therapy, late in therapy, and regardless of renal and hepatic impairment, because it could be given in those patients who have renal or hepatic impairment. Also, it has a cardiovascular safety, and overall safety has also been proven in various studies. So that's all for the day. Thank you.
Thank you, Dr. Alankar. It was a very nice and illuminating talk on obesity. So basically, I being a surgeon, I would like to ask you, basically now obesity is a metabolic disease. And we can say in a way now obesity is a surgical disease also. So when will you propagate surgery in a patient of obesity?
So according to the guidelines, if a patient is having BMI more than 35, along with comorbidities like diabetes or cardiovascular disease, we recommend surgery for those patients, or in patient who is not having any kind of comorbidity and BMI more than 40, then also we recommend for the surgery. Or if patient is not responding to the medical therapies or lifestyle changes also, then also surgery is recommended for those patients.
Thank you. So in a morbidly obese patient, that means BMI more than 40, we will generally be prescribing bariatric surgeries. Now that can either be a sleeve gastrectomy or it can be some restrictive surgeries. But along with that, it's a multidisciplinary approach. Obviously, the endocrinologist will be. And the patient must be motivated, because after the surgery, diet control is a very must. Otherwise, you will again be. Any questions?
Any questions from the audience?
Hello, Doctor sir, after COVID, what is the role of COVID in obesity?
कोविड इन ओबेसिटी
जी, मैं 2 बार कोविड पॉजिटिव हो चुकी हूँ, तो मुझे लगा कि
कोविड
शायद
का एज सच कोई रोल ओबेसिटी में तो नहीं रहा है,
हाँ।
पर ये है कि कोविड ने सबकी लाइफस्टाइल को इतना हैम्पर किया है क्योंकि एक्टिविटी कम हो गई, बाहर की हमारी एक्टिविटी कम हो गई, खाने पीने का इरेटिक हो गया, डिजीज अपने आप
वायरल लोड बढ़ने से या बॉडी में ज्यादा
नहीं मैम, ऐसा अभी तक वायरस का ओबेसिटी पे इफेक्ट नहीं पाया गया है। ओबेसिटी का इफेक्ट वायरस पे पाया गया है कि जिनमें जो भी ओबीस पेशेंट रहे हैं उनमें कोविड-19 की सीवियरिटी ज्यादा पाई गई है।
कोविड से ओबेसिटी का
डायरेक्ट रिलेशन नहीं है, डायरेक्ट रिलेशन।
ओके, थैंक यू।
Any other question? Thank you, Dr. Alankar. Thank you.
I would request Dr. Sujit Singh sir to please come on the stage and honor the speaker, please. I would request Dr. Sujit Singh sir to please hand over the certificates to the chairpersons, please.